Welcome everyone to the Association of Academic Health Centers annual meeting, a premier virtual event. We will be starting today with our first event for the annual meeting series, and I will be giving the floor to Dr. Angela Franklin, President and CEO of Des Moines University. Dr. Franklin, you may begin.
Good morning, everyone. It is a pleasure to be with you. Welcome. I'm delighted to introduce the first webinar of the 2020 Association of Academic Health Centers annual meeting series, a presentation on implications of advances in IT, AI ecosystem assets for academic health centers systems. It is an intriguing topic. Hopefully you, as I, have been really excited about the prospect of learning more, hear more from experts in the field. Before we begin, a few housekeeping notes. To ask a question, please use the Q&A feature at the bottom of the screen. And in the event of any technical difficulties, please keep an eye on your email. It is my pleasure to introduce someone that may be new to you, but someone who's quite well known to me and my university. Dr. Vincent Grasso is a global practice lead of healthcare and life sciences for Ipsoft. Ipsoft is the world's leading private artificial intelligence company. His role involves the design and construction of innovative enterprise healthcare and life sciences solutions, incorporating the company's AI ecosystem assets. Dr. Grasso leverages his subject matter expertise within the domains of healthcare and life sciences, technology, and business to optimize value contribution, market differentiation, and competitive advantage within the global marketplace. His educational experiences includes an MBA in finance and business process reengineering from the University of Massachusetts Amherst, a Master's of Science in Information Systems from New Jersey Institute of Technology, a doctorate of osteopathic medicine and surgery from Des Moines University, a fellowship in medical informatics from NASA, Yale University Commercial Space Center for Medical Informatics and Technology Applications, and a fellowship in advanced minimally invasive surgery from Yale University School of Medicine. General surgery residency from Mount Sinai School of Medicine and an internal medicine internship from Robert Wood Johnson School of Medicine. Quite a busy and impressive background. He's been heavily involved in agile software development methodologies since its inception, holds certifications as a certified Serum Master and Project Manager. Dr. Grasso has been active in global humanitarian relief efforts and has received governmental recognition of humanitarian service from several countries around the world. It is my pleasure and honor to introduce to you Dr. Vincent Grasso, the Global Practice Lead of Healthcare and Life Sciences for Ipsoft. Thanks, Dr. Grasso, you may begin.
Thank you. Thank you for that kind introduction. Can everyone hear me okay? Can you hear me okay, Dr. Franklin? Hello?
Yes, we can hear you.
Fantastic, great. It's a great privilege, and I appreciate the opportunity just to speak to the organization. This is a very exciting time for us all. As you stated, I have the great pleasure of being a graduate of DMU and excited to see the new innovations that you're undertaking there under your leadership. So we see ourselves over the next 5 years, I think, on the forefront of bringing some new innovations to the healthcare delivery system in general, especially well suited for academic health centers. As you stated, I have the pleasure and privilege of leading the healthcare practice for Ipsoft. We are an interesting company. It's about 20 years old, and we have a very interesting platform for conversational computing. So I wear that hat, and I'm very busy with that effort. I think what's maybe more of a pro for the conversation as well is that I'm still a practicing physician. And I practice part-time, although I'm trained as a surgeon, as you stated. I'm doing family practice in an inner city clinic that serves the medically underserved and economically disadvantaged in Newark, New Jersey. And I've been doing family practice for about 1.5 years there, and especially relevant during the COVID crisis. I'm also the chief technology officer for evolving federally qualified healthcare center that services patients in the south side of Chicago. And it's acting as a beta site for work that we're doing. So I have the good fortune of being able to use my technical and business expertise by understanding and leveraging these assets we'll discuss. But also, I'm in the trenches. We've been working literally 7 days a week since COVID hit, doing telemedicine and inpatient visits. So this is a very interesting time. Just to touch base on the COVID impact, we all have family and friends that have suffered during this pandemic within the international space. I have family members that died. We couldn't have appropriate burial ceremonies for them. Patients that have died, families that have been disrupted through the unfortunate impact of social distancing and being at home, et cetera, et cetera. As a practicing physician, I do have access to the patients that are in our practice, the chronically ill. We're seeing lots of morbidity and mortality related to the distance between our clinic and servicing these patients. And one of the points that have come up is the substantial decline in cancer screening. As you see in the top right there, the American Cancer Society has reported massive decreases in scheduled screenings.
Dr. Grasso, apologies for interrupting. I believe the PowerPoint needs to be shared. There's a technical difficulty with that. If you could load it up again.
Sorry about that.
No problem.
Let me reshare it again. Is that okay? Can you see
Yep,
that?
you're all set. Thank you.
Okay, so sorry about that. I must have come out of share mode. So as I was stating, the ability to screen our patients that are normally being done in-house, cervical cancer through pap smears, mammograms, colonoscopies, screenings in general that are handled by our medical assistants and our staff, and including physicians when we examine patients. This has been significantly affected. The graphic on the left, the impact on family financial decisions. The affluent and those of us that fortunately have jobs that can weather the storm. We have savings. We can float. We can ride the storm out. But if you're working in a cash business, you're a restaurant employee, and you're working, but you really don't have a good buffer to deal with this. There's profound impact on what you need to do in order to pay your rent, get mass transit fare, have copays, pick up prescriptions. It's a saga, and this COVID situation that we're in is in fact the manifestation of the decentralization of healthcare delivery, which we'll talk about. We're not prepared as a society to really deliver care in toto to patients that remain at home, where we need to have our systems of record access them and our staff. So this is a problem, and it's not getting better anytime sooner. And as we move into the winter months, depending on where you live, there'll be additional barriers to face-to-face patient encounters. Let me move on. So this is a slide for the purposes of communicating what I would call the complexity of having systems, academic health systems, others, decide that they're going to go on a journey to assess, test, incorporate perhaps artificial intelligent assets. And the rationale behind this slide is the following. Utilizing these technologies is going to impact the business. You may have rather abrupt changes in workflows. A lot of these assets, in fact, do provide the opportunity for re-engineering of workflows that weren't possible before, that will impact patient care, impact cost, impact patient satisfaction. And the simple slide on the right, the graphic on the right, relevant to the domains. is what I feel to be rather important if an organization is going to embark on this journey. And the domains of clinical healthcare, right? That's a domain. Technology and the business processes associated are all impacted by bringing these assets into clinical workflows and organizations. If you only have a champion that represents the clinical side and you don't have the business and technical folks at the table, you have a very difficult time moving from maybe a proof of concept pilot to production. If you have simply the technology folks involved, so the CIO or the CTO was very excited about something and they want to do a pilot, and the business folks were left out, the clinicians were left out, you may have a successful technical integration, but it doesn't move to production. Same on the business side. And by having the triad of the domain experts, the technology representatives, and the business folks at the table together, you have the best chance at harmonizing the experience of introducing something like conversational computing, a digital agent, into your workflow and making the appropriate changes in a multi-phased effort. So the best teams are the ones that spend a little more time really looking at this and what are the implications of consumption of these assets and utilization. And there's a much smoother transition. So I'm bullish on doing a lot more thinking up front. You don't spend money when you're thinking. You spend money unnecessarily when you didn't do enough thinking up front. And beginning to look at how these things could impact clinical workflow, et cetera, over a multi-phased effort. Let's look at an example, the evolving medical assistant. I have medical assistants in our clinics, and they work very, very hard. They can only accomplish so much in a day. They don't work 24 hours a day. They don't work on weekends unless the clinic's open. And they're very diligent, and frankly, they don't really get paid, I think, enough for what they deliver. But right now, it's a human labor workforce. There are people working, they work with us, we work together, and that's pretty much it. The Silicon labor workforce is kind of there's a fear. There's an antiquated notion that robots are going to replace people. Robots help people. In some instances, they replace them. But for the most part, what I'm seeing evolve on the landscape is the hybrid labor workforce, where synthetic humans, digital assistants, and organic humans, right, real humans like we are, work together. The picture on the bottom right is an interesting photograph of two young ladies. The one on the right is human. The one on the left is synthetic. This technology is getting better and better at representing people in intriguing manners, emotionally correct, facial features correct. They get better, they become less expensive, and they are evolving into this hybrid labor workforce. The statistics on the left are rather interesting. I do house calls. I have lots of seniors in the family. This is an evolution of complexity that we're all experiencing. Think about New Jersey with 9 million people and 1.5 million seniors. And there's about 350,000 retirees on pensions. There's about $11 billion in benefits spent. There aren't enough medical assistants to go around and be engaged with these patients at home. The medical assistant schools aren't graduating enough people to meet the demand of having a workforce be directed to homes. In my view, and the folks that we've been talking with, this hybrid labor workforce is in fact the potential solution to this dilemma created where you have massive demand for competency and you don't have a delivery mechanism behind it to handle that demand. So the medical assistant environment is evolving, very interesting, and I see them being able to deliver a lot more value than what they're asked to do in our clinics. So these are discussion topics that have been accelerated by COVID. I'm very involved with designing systems that deal with patients in a decentralized environment. Centralization or decentralization, I'll define that. If patients leave their homes and take a car, a bus, an Uber to a physician's clinic or a hospital, they are moving to the center. That's a centralized model where the infrastructure is centralized and people that live in the periphery come to the center. The inversion of that is a decentralized environment. Make believe everybody in the United States for the next month stayed home and didn't leave their home at all. They all stayed home. How would you deliver healthcare to all of them? How would you deliver diagnostic testing? How would you screen them for various ailments? How would you send them their prescriptions? How would you do blood work? How would you talk to them about their laboratory tests? You'd have to bring that infrastructure out. And that's not an easy undertaking. Naturally, we don't have the infrastructure yet to do that. But a hybrid digital workforce is part of that unraveling of the delivery system to meet the demands of a decentralized market. How are healthcare systems and academic health systems especially, how are they going to accelerate the digitization process? Are they afraid of it? Does the C-suite possess relevant domain expertise? Every hospital system I'm aware of has a CTO or a CIO. Does it mean that they're all up to the task of being able to engage in this new environment? Certainly consultants are there to help, but consultants are designed to be paid for what they do. And you know, there's a complex dance working with consultants. So I'm very excited about, but also cautious that a lot of the dilemmas that we are witnessing through the COVID-19 pandemic, restrictions on mobility, have in fact illuminated a lot of flaws in our delivery systems, which can be in fact addressed through the judicious use of AI ecosystem assets, which we'll talk about. There's three buckets that I consider relevant to this discussion. Conversational computing. Now, we talk about chatbots. Chatbots are rather simplistic. They're very good at binary discussions. Yes, no. Did you check your blood sugar yesterday? Yes or no. They're binary. That's easy. So conversational computing is in fact the face, the front end of how you engage with the platform that's in the cloud, and you're going to communicate through the voice or text or both and video. And that's the front-facing framework for how patients and other stakeholders will engage. On the back end, there's machine learning that's available. How do I ingest all the relevant data? How do I look at these data sets in intriguing ways? How do I extract value from them? I'm not talking about simply, how many patients yesterday, took their blood sugar. That's not machine learning, right? That's simple analytics and reporting, but that complexity. And then the robotic process automation is rather interesting because it allows you to re-engineer process. I won't tell you how much time in my day seeing about 25 patients is consumed by tasks that could be offloaded to RPA-related automations. How many boxes I have to click in my EMR to send an orthopedic consult. Things like that. Lots of stuff in the back end can be automated. So there's three legs of the stool: conversational computing, RPA, robotic process automation, and machine learning. The trick is, what do you use when and how? How do you integrate it? How do you develop into it? Who's the thinking leadership on trying to engage with these new wonderful abilities and capabilities? And this is part of the discussion of why you need to have the clinical representatives, the technical representatives, and the business representatives at the table to really go through and explore where there's demand for these types of newfound, again, abilities and capabilities. Let's just look at the conversational computing play. These images are, again, not real people. The young lady on the left, Ava, is actually a model. She's an actress and model in New Zealand. And this is a representation of her. It's highly accurate. And when you engage with Ava conversationally, her facial features move and mimic, just like yours and I, and we all do emotionally, smiling and frowning and etc. So that's Ava on the left, and there's a little boy on the right that's ultra realistic. And what that does is it provides an opportunity for the patient, a stakeholder, to engage naturally with a digital human. Why is this so intriguing? Think about our healthcare systems. 3 o'clock in the morning, pretty hard to be able to engage with your healthcare system and answer questions. You're using your phone, cell phones, you've got your tablet, you have your laptop. How do you move the experience in that omni-channel environment? Is it multilingual? Are you able to speak Spanish, have it translated into English to someone that's going to work with you and translate it back into Spanish? Who's doing that? Is it cloud-based? How do you access all these systems of record, your CRM, your EMR, your billing system? How do you do all that? So the richness of your experience is in fact a function of your integration. And the richer your integration is, the richer the conversational experience becomes. Here's an example of a screening tool environment. This is Amelia. She's our conversational agent. I have built, when COVID hit, I built our COVID screener that went live and was picked up by a lot of organizations. But think about the screening tools we do in family practice, internal medicine, etc. There are lots of screening tools. We don't get a chance to do all of them. We try. But just think about the opioid risk assessment tools that you're obliged to every month evaluate all your patients on opioids. The pre-diabetes screening tools, hypertension screenings, aneurysms in adult males, abdominal aneurysms, and all the cancer screenings and everything else. This is really a large effort. There are hundreds of questions that need to be asked and addressed. And you did see the American Cancer Society, unfortunate statistic of about half of these screenings not being done because of social distancing and the COVID saga. So screening tools are a rather simplistic way of getting access and being able to understand how these tools work. RPA is interesting because it's the back end of the back and front office tasks that are done repetitively that can in fact be done in a robotic process manner. This doesn't mean that people lose their jobs doing appointment scheduling and billing, etc. What winds up happening are the humans that are doing scheduling, in fact, work with patients that have a scheduling problem that needs to be addressed, a complexity. So humans are really good at dealing with multiple variables at the same time. And that's in fact what they excel at. And that's where they can bring the most value. So the blending of the hybrid workforce, the human and digital workforce, is really a kind of special sauce. There's a recipe to it. When do you use which and why? But you can see where the little categories of physician credentialing, appointment scheduling, etc., lend themselves very well for these types of technologies. Now, this is my MBA was in finance and business process reengineering, and this is a diagram of a business process mapping notation chart. And why this is really important is this modeled kind of the involvement of a visiting nurse organization going out and seeing patients at a resolution level, say 10,000 feet, where you see that patients request a visit on the lower left. There are office clerks and nurses and billers and office management people and the doctor all involved in this drama, this saga of going to visit patients at home, generating bills, getting data, sending out a report, sending out a claim form, getting paid. This is a simplistic view, and no rocket science in this. But however, I will ask you. I bet most of the organizations that are on the call may not have workflows documented in this format, which is a formal industry standard format. And why this is important is the conversational computing agents we use actually read these types of documents. They follow workflow based upon the formality of a BPN. If I was in charge of the healthcare systems I play with, I would have all department leads be educated in designing and building BPNs so that you'd have, in fact, all the workflows documented for review purposes. And believe me, the eureka moment comes all the time where you realize, wow, I didn't realize this thing took so many steps. Why is that? Well, okay, because you finally sat down and really looked at it all and documented it. So this is I would call a must-have if you're going to play in the space of bringing these new capabilities into the delivery system. Home-based medical device management is really intriguing too, because now it's much easier to be compensated for remote patient monitoring. More devices are going into the home. Okay, how do we manage all that? How do you start managing devices pinging up to a cloud-based application? Who's notified, when, why, how do I escalate, what do I do? These are all back-end processes that respond very well to automation. And without having the automation, you have to have an enormous workforce that kind of counters the benefit that's derived from remote patient monitoring. So there's the catch-22 of doing it the old way is expensive, so I don't do it. Doing it the new way requires me to have some new tools I don't understand. So there's the dilemma, but there's really no way to go backwards. There's no financial mechanism that allows you to do this at scale. So these are the kinds of examples of what RPA brings to decrease the cost of, say, deploying a device, an IoT experience for your systems. Machine learning is rather intriguing, right? And we talk about this all the time. How do I extract data from the EMR that I don't have? How do I integrate the CRMs, the customer relationship management platforms, the billing systems, the EMRs? What magical insights can I find out? Well, there's no real magic. If you configure your backend systems correctly, you can take advantage of what machine learning affords you. But that's not at the neglect of doing what you're supposed to do in the first place, is getting good analytics and reporting from your data. So if you're not doing good analytics and reporting and then want to jump into machine learning, you may not have a good experience because, frankly, the organization isn't prepared to take advantage of this, what I would call more evolved technical feat. So EMR data and other systems of record can be integrated, and machine learning brings a lot to the table to extract insights into vast populations that you will not be able to have through normal analytics and reporting. And the utilization of non-EMR data is rather interesting. Just the two quotes on the top left. My diabetic patient is really non-compliant with his care plan. I don't get it. We have discussed the importance of this so many times. This is a lamentation of a provider about the non-compliance of a patient. But let's think about the second paragraph. John lost his job. He has difficulty getting his meds because he has to take a bus to get to the pharmacy, or it's not too close to walk. He's lost his job. He's eating fast food because McDonald's offers hamburgers at $1 a shot. And he needs to take 2 buses to see his PCP. And his PCP is in Chicago, where it's now winter and it snows. So he may not be non-compliant because he doesn't want to be non-compliant, but this data, where he lives, how far his home is from the pharmacy, access to credit card transactions without intruding to see what he's eating, recognizing that he needs 2 buses through a Google Maps integration to know how he goes from where he lives to the doctor office. In a predictive model, this is the setup for a patient that will have difficulties complying, simply logistical and income-based. So the ability of looking at the disparate data sets do in fact provide opportunities for enhancing the predictive modeling that we had done in the past. And perhaps John Smith needs to be really looked at in a different manner. He may need to change his PCP. We may need to help him change his PCP. Not that we want to lose work, but we want to do what's best for him. So there's a recipe that allows all of this disparate data to make business and clinical sense for our patients. So just in summary, delving into the AI realm, in my opinion, requires organizations to have competency and a willingness from the stakeholder triad of the business, the technical, and the clinical. Now, human workforce, I don't think can meet the demand in this decentralized environment. And the hybrid workforce does provide some interesting abilities that would allow us to scale at a de minimis price. Re-engineering expertise is important, at least from a documentation perspective, to document the as-is versus the to-be model, the new model. And in the lower section, the design, integration, and deployment of all of this should yield, I think, sizable savings, sizable cost reductions through ability of replication and scaling and monitoring, improved clinical outcomes. When I know something is wrong, how long did it take me to intervene, and what was the clinical yield from that? And in my experience dealing with patients in my betas and in socializing this to them, I haven't had many patients that say they won't engage. In fact, they say the following: Dr. Grasso, did you design this? Yes. Do you trust this? Yes. Well, then I trust you, therefore I'm going to trust your emissary. I trust who you've sent to me. And that's I think the underlying message is we want to maintain that relationship with our patients of trust, and certainly never do anything that surprises them, hoodwinks them, lies to them, or have them go down the path that we really haven't vetted fully. Thank you for your time. Looking forward to some questions.
Thank you, Dr. Grasso. We do have a few questions, but I just wanted to begin with one comment and a question. Of course, it's fascinating and impressive work here. And I was struck by one of the slides when you talked about the need for documenting and tracking and plotting out the workflows. And I can imagine there's a workforce and a skill set out there to be developed. And I can imagine, I'm thinking this way, maybe others on the call are wondering, what are the costs involved in being able to do something like this? And what do we need to do in preparing the next generation of a workforce, not just the clinical providers, but those individuals who are going to administer this new technology?
A great question. And to address the first part of it, I've had success in having medical students that I've mentored and employees in our own organizations go through what I call a kind of little boot camp. I've had people in one day be able to understand how they construct those types of documents, those workflow documents, because they understand the foundations of them. When you understand the foundations of them and what's required, if you know your domain and you know your workflow that you're responsible for, it's rather easy to document it in that format. So it's no Herculean challenge to do that. I think all medical students, frankly, while they're in school prior to residency, would benefit immeasurably from being able to, get habituated into the documentation of workflows from that perspective. Think of the benefit they bring their residency programs, the benefit they eventually bring their clinical practice. So I think it starts in medical school. I think that's the time to have our students learn about what this all is and get very comfortable with it right from the beginning.
Right. So we have a question from Andrew Boyd. How do we prevent the inherent health disparities in our current health system from being replicated and made worse by AI systems?
So that's a great question. So I'll answer it by what we're doing in Chicago. In the federally qualified healthcare center network we have in the south side of Chicago, there's an enormous demand for interaction between patients that are within that community and their healthcare systems. Traditionally, healthcare systems address patients through high cost labor, human labor, and the requirements of transporting yourself to brick and mortar facilities that, they already have had an investment in. The way to address the masses, and unfortunately the medically underserved and economically disadvantaged don't have access to this technology in and of themselves, is the cooperation of the solution vendors, the technology partners with the academic health centers, the healthcare systems, and private not-for-profit partnerships. We know what these things cost, and they are expensive. But I will tell you, they've come down in the past 2 years dramatically in price. So you can consume these assets at a de minimis price. The expense is actually in building and integrating what they do. But once it's been built, they scale, and onboarding large volumes of patients require a minor increase in overall cost. So with scale, in fact, the cost goes down. Human labor doesn't work that way. You have to hire more bodies. And that's why the hybrid digital, hybrid workforce allows you to offset the cost of the solution to the reduction in the cost of labor and the value that's offered by having a 24/7 environment.
Thank you. Another question from Ali Karshinas. What are your thoughts on AR, VR, MR technology in service-oriented environments above their values in teaching and learning?
Is that question referring to like virtual environments and artificial? So the digitization of healthcare means that you went from an analog environment to a digital, right? Once you make that leap into the digital world, the entire potpourri of digital assets become available. Better graphics, immersion in virtual worlds, high performance computing, conversational computing, etc. So the systems that are making a digital journey, in fact, have the opportunity to utilize these assets. So could you have patients immerse themselves in a virtual world to learn how to do their dressing change? Yes. Does that application exist? Perhaps. Somebody may have built it already, or you would need to integrate it yourself. But the challenge is to simply be able to identify the demand, the need that you have, and then like most folks, go and find the solution that you can either buy or license and or build with your team. So it's wide open to which part of this you would utilize to solve your problem.
Well, on the call today, I'm sure we have quite a few leaders in academic health centers, with varying degree programs, providers of the future. You mentioned medical students before, but what are the implications that this work has on the way medical education in general should evolve over the next 10 years? What happens within our environments that we should do differently to prepare the next generation of providers?
Well, when you look at my background, I was trained in some very serious organizations, right? My fellowships and my general surgery residencies were in great places. And I graduated and I didn't understand anything about medical billing. I had no understanding of billing. It was never spoken about. I had no understanding of the business operations of the clinical side, the running in an office. So I think there's a disservice perhaps of having our medical students and residents graduating without the following: not really understanding what takes place in the business of healthcare so that you could in fact bring more value, not understanding the technical fundamentals of what's required in a digital age and how you can in fact bring value to that. I know lots of electrical engineers and computer scientists that were undergraduate that went to medical school, and a lot of that skill is never really leveraged by the systems that they practice in. So if you think about a healthcare system with 2,500 physicians, if you just looked at their undergraduate degrees, you'll find a whole slew of people that have physical science backgrounds, whether it's computer science or engineering. And that's a whole talent pool that's never really tapped into very well. So I think it starts at the medical school, getting the students acclimated and understanding of what digitization in healthcare really means and what they could learn and how it could benefit them. And it falls through residencies. I'm a big proponent of getting certifications, certificate programs. I mean, I got 2 masters after my surgical residencies because I wanted to learn and really immerse myself. I don't think you need to go that far, but certainly fundamentals of database, fundamentals of data visualization, and medical billing and finance. I think these all bring a lot of value to your future employers and in fact, at the end of the day, the patients that you service.
Given your experiences, what you know, what you do, what advice would you give to those of us on the call who are intrigued with this, can imagine a future that looks different than the current way we deliver care or even train our future providers? What advice do you give to us? Where do you start? If you're wanting to begin a process, what are the first steps?
So for me, first steps are, and we call in business process mapping, we call it the as-is model. You need to document what you're doing right now from the perspective of, say, the diagram that you saw. Let's for example, talk about how does your system manage the diabetic patient? What does it do? How do the case managers get involved? What do they do? How do calls come in from patients with blood sugars at 450 that they just found? What happens? How do you know whether the patients picked up their insulin or their metformin at the pharmacy? And if they didn't, what do you do about it? These are basic questions that need to get asked well before you start thinking about, well, let's just get a conversational robot and they'll make all these calls for us. It's sound, and I'm not being sarcastic. You would be surprised, although a lot of these things are taking place every day, they're not really centralized and coordinated well. So those are the kinds of exercises that you go through first. How are we caring for our diabetic patients? How about our hypertensive patients? How about our patients that have hyperlipidemia and hypertension and diabetes, the high-risk patients? What do we do different? What do we do different than we don't do different? How about the prenatal patients that we have? How are we optimizing nutritional services for them? So you ask a lot of questions. You beat yourself up in the question and answer realm before you start making the migration into whether these things apply to you or not. They will apply, and they will apply in a better manner once you really documented how you're doing things now. That's the as-is model. And that's not costly. That just requires a lot of internal thinking and being honest with yourselves in a private setting. And I've seen that work every single time it's engaged.
Great. One more question from our participants. What are key factors to fostering a culture in order to shift our mindset on the implications of AI and how to begin to adopt various forms of AI in our environment? Medical, educational, healthcare delivery, operational, and research.
Yeah, it's a great question. This is a journey. There's what I have found in the healthcare systems that I'm dealing with, and in fact, the customers that we've serviced outside healthcare. When you embark on this journey, there should be transparency and an opportunity for folks that in fact have some skill sets you weren't aware of to be at the table. These things done in secret, these innovative projects being done behind closed doors where all of a sudden there's a digital agent in your call center and the call center employees weren't involved, that just creates mistrust. And you want these early pilots to be transparent, appropriate people on board with lots of conversations about how this is going to bring value to the system, to the employees, and the patients. And if you don't go about it that way, then you run into the, and we've seen this before, where there are surprises and the workforce gets nervous and suspicious, and that means their productivity goes down. And then the good ones leave. So I think first order of business is transparency, appropriate stakeholders at the table, representative of all the groups that'll be impacted directly and indirectly, and then the socialization of that and some concepts about the timeline. We're thinking about doing something in Q1 2021. It'll address this. Here's why. And just the open communication between all these channels will pay dividends down the road, because if the first one succeeds, it'll be that much easier to do 2, 3, and 4. So that to me is the best way to proceed and seems to yield the best results.
Great. Thank you, Dr. Grasso. As we prepare to close here today, do you have any final remarks, comments, words of wisdom, encouraging statements to give the group here today?
I'm bullish on the ability of these assets to bring value. I think patients are very excited about using something that will help them at home, help their loved ones. I haven't had a patient yet really be ultra negative about the vision. And if you can in fact deliver a better quality healthcare product at a lower cost with a better clinical outcome at scale, where patients, regardless of their socioeconomic status, benefit and they're happy, that's about as good as it gets. I'm not too familiar with many things that achieve that, but I'm absolutely convinced that done properly, we could make that triad.
Great. Well, Dr. Grasso, I can't tell you how pleased and proud I am to have you be one of our distinguished alumni of Des Moines University, and really want to thank you for all the great work that you're doing in this space. And, you know, it seems like there's so much more on the horizon, more for us all to learn and understand. And we really appreciate your time today. So want to thank you for being with us.
That's my pleasure. Thank you.
Great, thank you. Before we end, just want to be sure to save the date for some upcoming Association of Academic Health Center meetings. Stress management in the Academic Health Center is scheduled for September 29th. Health plan ownership and AMC perspective on September 30th. A series of AEHC annual meeting sessions beginning for the annual meeting, all virtual of course, October 7th through the 9th. Please go out and register online. Registration fees are waived for all members. We hope you enjoyed today's session and look forward to seeing you again soon. Thank you all for being with us today.
Thank you all.